A PAP and random biopsies were done. Her PAP came back as HSIL encompassing moderate and severe dysplasia, carcinoma in situ CIN2/3, and HPV positive, and the cervical biopsy showed HSIL CIN3 with focus of invasive squamous cell carcinoma, although depth of invasion could not be properly evaluated. The patient was notified of the path and referral was made to gyn-onc. I just wanted to briefly go over cervical cancer staging and workup. For this image here, it kind of shows that stage 1 being more confined to the cervix, stage 2 involving the upper vagina and parametria, and stage 3, the lower third of the vagina and extending laterally to the pelvic sidewalls. And it could cause hydronephrosis, and as well as stage 3 being pelvic and periaortic lymph nodes, and stage 4 being spread to more distant organs or invasion into bladder or rectum by biopsy. So for cervical cancer staging, it's changed a little bit recently to allow for imaging and pathologic and examination to all contribute towards the staging. So things like history and physical examination are important, sometimes cone biopsies as indicated, and imaging with pelvic MRIs, PET CT, CT chest, abdomen, pelvis to evaluate for extent of metastatic disease, as well as EUAs, cystoscopy, and proctoscopy to evaluate for bladder or bowel involvement. I can take any questions at this time.
I see that Dr. Silverberg has his hand up.
Hi, Anusha. Really good presentation. My question is, I'm really surprised by her first GYN exam. We couldn't see this, what seems to me a very obvious late-stage cervical cancer. Could you comment on that?
Yeah, so the first examination in terms of documentation that's there, the first examination from February, just a speculum exam was noted, no bimanual exam. So I'm not sure if anything was palpated, but on speculum exam, there was a little bit of blood noted in the vault, about 10 cc's. So I don't know if that obscured some of the visualization of the cervix, but aside from that, I'm not sure how obvious of the lesions were noted at that time or able to be noted.
Let's see.
Dr. Leiser?
I'm curious, in a patient who was this sick and had this much bleeding, was there any thought to just taking her for an EUA and maybe, DNC biopsies instead of doing this as an outpatient? It's easy to Monday morning quarterback, right? But just kind of listening to this might have been a patient that I would have wanted to just figure it all out while she was in-house.
Yeah, I think that's a good point. I think, like you said, looking back, that's something that could be done differently. Again, hindsight is 2020 now that we know the final pathology. But I think for this patient, given that she had presented multiple times and that too between the February and the March, she was unable to follow up with the GYN outpatient. I think she's someone who is at high risk for being lost to follow-up or not being able to get proper follow-up. So she's someone who could have benefited from inpatient, just taking her to the OR. And initially, I think a lot of the thought for her vaginal bleeding was just abnormal uterine bleeding. And so thinking, even if she was going to the OR to get an EMB or a DNC, maybe at that time her cervix would be able to be better evaluated and something else would be seen. She had also not had proper PAP follow-up, so a repeat PAP at that time, if her bleeding wasn't significant, could have been helpful as well. And yeah, I think that's something looking back that could have been done maybe differently.
Anusha, hi, this is Dr. Goldberg. I think we certainly dropped the ball for a lot of this patient, unfortunately. She needed an exam. I think that was the basic thing. She needed a good pelvic exam. And so before that, as you said, the thought was she had, dysfunctional bleeding from anovulation. But, clearly when she had a good exam, it was clear where the bleeding was coming from. And, she also had some, as we talk about social determinants of health, she had transportation issues. She has 4 young children. She's alone. So I think doctor was right about, maybe doing the workup in the hospital if it had even been thought of. If we felt, a rocky, hard nodular cervix, I think at the first visit or even the second, she's been walking around with percutaneous nephrostomies for 8 weeks now. Most people don't do that, and she bled heavily, and I'm sure she bled more than just the first visit. She had to bleed more than one day to have a hemoglobin of 6.5. So,
Dr. Goldberg.
I think we could have done better. Sorry, Dr. Eber.
Okay, thank you so much for your comment, but we are over time and I will get yelled at by the CME committee. Thank you, Anusha, for that great presentation. But it's time now to transition into grand rounds. In a minute, I'm going to ask Dr. Sweat-Patrick to introduce our grand round speaker. In the meantime, with regard to attendance, the person who's signed in only as iPhone, you have not responded to my messages, so I'm going to have to boot you in about 5 minutes. So please, everyone, pay attention to the fact that we must keep track of attendance, both for academic reasons as well as security reasons, and sign in with a name that is legible. So with that, Dr. Patrick, are you ready to introduce our speaker?
Yes, I'm ready. And it's a real pleasure for me to introduce our grand round speaker today. We have with us today Dr. Ashley Battarbee, who's an associate professor in the Division of Maternal Fetal Medicine at the University of Alabama in Birmingham. Her primary clinical and research focus is in the management of diabetes in pregnancy, with the goal of improving both short-term pregnancy outcomes and long-term maternal and child health. To that end, she's currently the principal investigator of not one, but 2 multi-center randomized clinical trials. One, which is evaluating the optimal method of glycemic management after antenatal corticosteroids. And the second, which is evaluating the effectiveness of continuous glucose monitoring for the management of type 2 diabetes in pregnancy. In addition to that, she also serves as the site PI for multiple other clinical trials of type 1, type 2, and gestational diabetes in pregnancy, and serves as director of the UAB Diabetes in Pregnancy program, which provides integrated multidisciplinary care for patients with diabetes in pregnancy. So as a fellow MFM and a former GDM patient myself, who put myself on a CGM in my last pregnancy, I am super excited to hear her talk today. And I think we're all going to learn so much. So thank you so much, Dr. Battarbee, for zooming in to New Jersey this morning. And I'll give the floor to you.
Thank you so much for that kind introduction, and thank you guys for the invitation to speak today. So I'm going to speak on real-time data, real-world management, the role of continuous glucose monitoring, or CGM, in pregnancy. In the interest of disclosure, I do purchase CGMs from Dexcom at reduced cost for research, and I have funding from a number of entities for research specifically using CGM. So our objectives for this morning are to examine key differences between CGM and self-monitoring of blood glucose, to then review the current evidence for CGM use in pregnancy, to identify, what is normal when using a CGM in an uncomplicated pregnancy, and then finally to apply a simple approach to interpret CGM data for clinical management. And my goal is to leave a few minutes at the end for questions. So, as many of you are aware, hyperglycemia is one of the most common medical conditions that women encounter during pregnancy. Up to 1 in 6 live births occur to women with some form of hyperglycemia, the majority of which are due to gestational diabetes. This is important because hyperglycemia is associated with increased risks of maternal morbidity and mortality, as well as perinatal morbidity and mortality, and also long-term health consequences for both mother and child. Furthermore, GDM is on the rise globally, making this a major public health issue. So we know that diabetes increases the risk of these adverse maternal and neonatal outcomes. And in order to mitigate these risks, we can work to achieve better glycemic control both before and during pregnancy. In the figure on the right, you can see that as hemoglobin A1C increases across the x-axis, there is an increased risk of congenital anomaly or perinatal death, shown in panel A, and an increased risk of perinatal death with an A1C in the third trimester, shown in panel B. What's also notable is when we're thinking about perinatal death or stillbirth, it's actually higher for patients with type 2 diabetes, shown in the red bars, compared to those with type 1 diabetes. So we know that traditionally we have used finger stick or self-monitoring of blood glucose to assess glycemic control throughout pregnancy, but this has many limitations. First of all, it's uncomfortable or painful to perform. It can be burdensome in someone's busy lifestyle and really only provides limited snapshots of glucose data throughout the day. So in the figure on the right, you can see kind of a schematic of what this might look like. So this is a patient who's been asked to check their blood sugar 4 times a day, fasting, and after each meal. In the red dots, you can see she successfully checked her blood sugar 3 times throughout the day, and overall it would look like it's achieving our goals. She unfortunately was busy after lunch and not able to check a blood sugar, shown in the open green circle. And this is, illustrates how continuous glucose monitoring can provide us with additional data that can help us better understand what's going on. So really, her blood sugars are not meeting our goals. There were periods of hyperglycemia that were undetected with the self-monitoring of blood glucose, as well as a period of hypoglycemia. So what is continuous glucose monitoring? All CGM systems measure interstitial glucose continuously with a glucose reported every 1 to 5 minutes. And each of these systems are essentially made up of 3 parts. You have the sensor, which is a filament that's inserted through the skin and into the interstitial space that is measuring the glucose levels. You have the transmitter, which is sitting on top of the skin, which is collecting all of those glucose measurements. And then it will send those glucose measurements to either a compatible smartphone or a receiver. What's important to point out here is that your sensor is measuring an interstitial glucose, which is not the same as your finger stick measurement, which is measuring a capillary blood glucose. And this is important because it takes some time for your glucose to diffuse from the capillary space into the interstitial fluid. And I'll illustrate next what that does. It creates a lag time. So it creates essentially a period of time where the CGM sensor is going to have to catch up to your glucose reading. So to illustrate how this might work in real life, you can see on the left what would happen if someone's blood sugar was stable and not changing. So in that instance, the CGM reading and the finger stick reading, we would expect to be about the same because the glucose has been able to diffuse across from the capillary to the interstitial space, and those blood sugar concentrations are the same. However, after eating, as the blood sugar starts to rise, you can think of this like cars on a train, where your capillary blood glucose or your finger stick reading is going to be higher sooner, and your CGM reading is going to lag behind as that glucose has not quite diffused across into the interstitial space. On a CGM receiver or a smartphone, this would be indicated by an up arrow telling you that yes, it's reading 109 at that point in time, but it is expected to go up. So you could infer that your capillary blood sugar would be a little bit higher than 109. And then similarly, if your blood sugar is falling, for example, after administering insulin or exercise, your finger stick reading is going to be lower sooner than your CGM reading. So again, using a smartphone or a receiver, you would be able to know that yes, your CGM is reading 145, but it's on the way down. So you would expect if you checked a capillary blood sugar at the same time, it would likely be a little bit lower. So these are some of the different CGM devices on the market. They are constantly evolving and coming up with better and newer technology. I'll point out kind of a few different things here. The first of which, most of these CGMs are what we call real-time CGM, where it does not require any intervention from the patient wearing the CGM. You don't have to scan the device. The device is constantly collecting data, sending it to your smartphone, and thus it can give you alerts if your blood sugar is high or low. This is in contrast to the Freestyle Libre 2, which is what we would call a flash CGM or intermittently scanned CGM, where you actually have to take your phone or a receiver, wave it over the CGM to collect that data. And so it won't know to give you an alert until you have done that step. The next thing to point out is the MARD, or mean amplitude relative difference, which is a measure of accuracy, shows that all of these CGMs are accurate. Good glucometers on the market have MARDs around 10%, so you can see that none of these devices are perfect, just like no test in medicine is perfect, but these are all considered very accurate devices. And then there are differences in the amount of time that it takes to warm up, but generally those are short. The devices typically will last for about 1 to 2 weeks, but there is an implantable CGM that lasts for a year. And then you can see that most of these are integrating with pumps and other diabetes technology, but some of that can vary by the device. So what are some pros to CGM? As we've talked about, it provides really detailed glucose data, which can be helpful for both the patient and the provider caring for the patient. It can reduce the need for finger sticks. It can help prevent hypoglycemia by sending those alerts so that you can make lifestyle changes to avoid a low. And then it also provides the immediate feedback of what happens when I exercise, what happens when I eat certain things, that the patient can adjust in real time. Some of the potential disadvantages are increased anxiety with the constant influx of significant amount of data. It can increase the risk of stigma or shame by wearing a device that other people can see. It can cause alert fatigue if you're, we all get bothered by many things that go off all the time. And so if your CGM is alerting all the time, you may get somewhat desensitized to those alerts. It can cause skin irritation. It can fall off. You can have falsely low readings due to compression, which we see not uncommonly if a patient rolls over on top of it in the middle of the night. And then, of course, the cost. So, but, is it beneficial? What does the data say? So first, the main landmark study on CGM in pregnancy is called the CONCEPT trial. It was a trial done of 215 pregnant women with type 1 diabetes at 37 different sites around the world. They enrolled patients who had a singleton gestation, less than 14 weeks, with a wide range of pre-pregnancy glycemic control and A1C of 6.5 to 10%. Enrolled participants were then randomized to either using CGM, which was a older Medtronic CGM, given the time period of the study was conducted, but they would use CGM and still check finger sticks 7 times daily with a glucometer. So that was the intervention group, compared to the control group, who was just checking finger sticks, again, recommended 7 times daily with a glucometer given type 1 diabetes. In this study, the target range for glucose was recommended to be between 63 and 140, which is what we commonly use today with CGM, and they had visits at least every 4 weeks. So what did they find? What they found was use of CGM led to a greater reduction in A1C compared to using finger sticks. So you can see on the right, their initial A1C average in both groups was right around 6.9%. And then in green, you can see the CGM group had a greater reduction in A1C as of 24 weeks, which remained lower at 34 weeks compared to the control arm. But there's 2 things we have to ask ourselves. Did they trade off high blood sugars for low blood sugars? So did they reduce the hemoglobin A1C solely by having more hypoglycemia, which obviously is not our goal? And then the second thing is, does a difference of A1C of 0.2% actually matter? It's a really small difference in terms of maternal glycemic control. So with regards to the first point, they did successfully use CGM to reduce hyperglycemia without increasing hypoglycemia. So really important from a safety perspective. You can see that the time in range, or TIR, was higher in the CGM group at 68% versus 61%. The time above range was lower, or time spent in hyperglycemia, which is what you want. And there was no statistical difference in the time below range, or hypoglycemia, with, if anything, a trend towards less hypoglycemia in the group using CGM. And this resulted in 1.7 more hours per day in target range. But again, does an hour and a half really matter with regards to the pregnancy? And it turns out it does. It turns out it probably matters more for the baby than it does for the mom. And so what they found was using CGM, again shown in green, was decrease the risk of LGA, decrease the risk of neonatal hypoglycemia, as well as NICU admission, with quite sizable effect sizes. When looking at the number needed to treat to prevent these adverse outcomes, it thus is very low. So for use of CGM for type 1 diabetes and pregnancy, you only have to treat 6 to 8 pregnant patients with type 1 diabetes to prevent these significant adverse outcomes. Particularly with respect to NICU admission, then it equates to not only being cost effective, but actually saving the health system money. So even though CGM does cost more upfront, when you're preventing significant, costly NICU stays, you actually are saving the health system money. So from that, we get our recommendations for type 1 diabetes and pregnancy from the International Consensus on Time in Range. For all pregnant patients, they recommend using that pregnancy-specific target range of 63 to 140. And then for type 1 diabetes, the goal is to spend at least 70% time in range, less than 25% time above range, and then less than 4% time below range. Unfortunately, there's has been insufficient data to recommend goals for gestational and type 2 diabetes at the time point that this was published in 2019. But you can see in their publication, they did kind of suggest or hint at the fact that potentially these patients could spend greater time in range with kind of a larger green bar, although there's no specific guidelines. So what does the data say about type 2 and gestational diabetes? Starting with type 2 diabetes, these are data from a systematic review and meta-analysis published in 2023. And so, looking at all published literature, they were only able to find 3 RCT that met inclusion criteria, namely doing a randomized control trial of CGM versus no CGM in patients with, including any patients with type 2 diabetes, and only 2 were of sufficient quality for meta-analysis. So in all of the publications out there, combining those, they were still only able to compare 56 patients who used CGM versus 53 who did not. So essentially highlighting the lack of data that exists for type 2 diabetes and pregnancy. And what they found, not surprisingly with such a small sample size, that there were no significant differences in large for gestational age or preeclampsia, and conclude that more data are needed. I will, because of the lack of data out there, I'll provide you with just a small retrospective cohort study that we had done at UAB as food for thought. We had collected data on pregnant persons with type 2 diabetes that had a non-anomalous singleton gestation, received prenatal care with us, and delivered from 2019 to 2023 to try and look at the association between CGM use and perinatal outcomes. And this shows our neonatal outcomes by CGM use. And you can see, again, in green is your CGM, and we had lower rates of composite morbidity, as well as nearly all adverse outcomes, suggesting that potentially CGM may also be helpful in type 2 diabetes. And after adjusting for confounding factors, we found that CGM was associated with an with a lower odds of neonatal composite morbidity, And that was driven primarily by preterm birth and NICU admission, but apart from shoulder dystocia, which really just has a wide confidence interval because of the rarity of the complication, all of these outcomes trended towards a benefit from CGM use. So then finally getting us to GDM, the first thing you can see, this is another systematic review and meta-analysis, is that there have been many more studies looking at CGM use for GDM. This meta-analysis was published in 2022, and they identified 6 RCTs. What's important to point out is that the CGM type that the majority of these RCTs had used, given that they were older CGM devices that are not as accurate as what we are currently using. They also primarily were masked CGM devices, meaning patients actually couldn't see their data in real time. They were collecting the data. Their physician may look at it when they come back to the office, but they couldn't actually see what it was after they ate, their breakfast in the morning. You can also see in general, these are relatively small sample sizes, although much larger than the type 2 diabetes studies, but were conducted across the world. So combining all of the data, what did it find? It found that using CGM in patients with gestational diabetes was associated with lower hemoglobin A1C levels, so favoring CGM use, and then for preeclampsia, no significant differences between groups. But what about some of our newer devices and how we actually would use CGM in clinical practice now? These are data from a more recent RCT that was a single center RCT performed out of OHSU. The publication is very, very close to being public. It's still under review, going through some revisions. But in this group, the investigators enrolled 111 participants who had been diagnosed with GDM clinically and had a singleton gestation at 20 weeks and randomized them to use either a Dexcom G6 CGM or to perform finger sticks. And their goal was to assess the efficacy of CGM in improving glycemic control measured by time in range. And here is what they found. They found that in green, the patients who used CGM had higher time in range, and this is across the 24-hour day, compared to patients who used finger stick. And then similarly, patients who had CGM use during pregnancy had a lower mean glucose, again, across the entire 24-hour day. What is also important to point out is when they calculate the mean time in range, these rates are much higher than we had seen in the type 1 diabetes concept trial, where the CGM group achieved on average 94% time in range, which was higher than the fingerstick group achieving around 88% time in range, but again, significantly higher than the 68% versus 61% in concept. Again, emphasizing that patients with GDM likely can achieve higher time in range. So what do our guidelines say based on that evidence? ACOG and SMFM actually currently don't have specific guidance on use of CGM in pregnancy. These are guidelines from the American Diabetes Association. They're standards of care that come out annually. And what they recommend is that CGM can help to achieve glycemic goals in type 1 diabetes in pregnancy. And then we just, kind of don't really know, but it may be beneficial for other types of diabetes. They recommend CGM use in type 1 diabetes in pregnancy based on the high level of evidence from the concept trial showing improved maternal glycemic control and improved neonatal outcomes. But then again, say that the decision of whether to use CGM in type 2 diabetes or GDM should really be individualized at this time. So that's great, but if we're using a CGM, how do we know, what is normal? What is our goal? What are we trying to achieve? And so the next few slides, I'll talk about data that was gathered in the GLAM trial, or glucose levels across maternity study. This was a prospective observational study of 768 pregnant persons who did not have either pre-existing type 1 or type 2 diabetes. They were enrolled at less than 17 weeks of pregnancy and wore a masked or blinded Dexcom G6 Pro continuously until delivery, again, to try and understand what is normal. And this is what they found. So in this analysis, they have that cohort, and they included only participants who had a early pregnancy A1C of less than 5.7%, so no one with prediabetes, and then patients who did not develop LGA, hypertensive disorders of pregnancy, or GDM. So these are approximating a normal, uncomplicated, healthy pregnancy. Here in this table, you'll see the CGM metrics, both overall throughout the entire pregnancy, as well as broken down by trimester. I'll start with time in range, since we've talked a lot about that already. You can see that the time in range is high, 94% time in range in uncomplicated pregnancies, and this is stable across pregnancy, so really doesn't change much from the first to the third trimester. Similarly, your average blood sugar is pretty low, 98 milligrams per deciliter, and again, fairly stable across the entire pregnancy. You can see some other metrics broken down here. Your time above range, I'll point out, also very uncommon. Only 2.5% of the time are you greater than 140 if you had just a completely uncomplicated pregnancy. And again, doesn't change over time, and very little time spent below range. What about across the day? So this is a graph showing, again, these are the uncomplicated patients, no prediabetes, no LGA, GDM, or hypertensive disorders of pregnancy. And then you can see the different lines are colored by the trimester. And then this is graphed over the 24-hour day. And you can see that overall glucose is stable across the 24-hour day. You might say, well, but it's like changing. You've got to focus on this y-axis, where really these changes are between 90 and 110 milligrams per deciliter. So if we plotted that on an actual CGM report, it would look like a pretty straight line, because we're used to seeing this y-axis, go from 40 to 400 instead of 80 to 120. So this whole graph fits within our goal for pregnancy. From that data, they were also able to calculate the CGM reading on average at 5 a.m. and 6 a.m., generally around 93, and then a peak postprandial glucose of 126, which really fits in pretty well with some of our goals for fingerstick testing as well. So now that we kind of have an understanding of what normal looked like, they were also able to look at, are there differences between patients who didn't develop gestational diabetes versus those who did in the days leading up until diagnosis. So this analysis was starting to explore, are there signs that we're already seeing that patients who are going to develop GDM are different from those not developing GDM? And as you would expect, or consistent with what we would imagine, there were differences. So patients who went on to develop GDM had higher, and this shows mean glucose, across the 24-hour day compared to patients who did not develop GDM. Again, this data is only including data up until the point that they were diagnosed with GDM, so does not include GDM management. And then this is that same data, just broken up into across the pregnancy, and then as well as in tabular format. You can see again, up until the point of a GDM screen, patients that ultimately develop GDM at higher average blood sugar and a lower time in range compared to those without GDM. And then these graphs on the right really highlight that this starts early in pregnancy. So even as early as 13 to 14 weeks, we're seeing that patients who ultimately develop GDM have higher, these graphs are showing time above 120 and time above 140. So based on some of this data that has accumulated with regards to GDM in pregnancy, experts have put out some guidance that really for patients with GDM who are using CGM in pregnancy our goal for time in range cannot be just greater than 70%. After all, going back to these other, these other data, if you look at patients who are going on ultimately developing GDM, their percent time in range before they're diagnosed with GDM is 87%. So our goal for management cannot then be just greater than 70%. It must be higher than that if we're going to improve outcomes in that population. And so they suggest that your time in range goal for GDM should really be greater than 90% using CGM with less than 5% above range, and the same goals for hypoglycemia. Still, that leaves this population, which is a major research interest of mine, with type 2 diabetes that we really, kind of don't know what the best metrics are for pregnancy. So all of that is great, but how do you actually use the data on a day-to-day basis for your patients that come in with CGM? It can be quite overwhelming. This graph shows an overlay of the glucose trends with the different lines by the different days of the week, and this is just 1 week at a time. So how do we evaluate this data and make management decisions that are going to improve our patients' outcomes? There have been, we put out some guidance in the Green Journal last year, which took a lot of notes and was similar to guidance that's also been published for internists and family physicians about kind of a simplified way to look at CGM reports. And I will try and challenge anyone who is a CGM skeptic thinking that it's too complicated and too difficult, that we really can make it quite simple and use the different strategies that you would traditionally use to review a finger stick, a blood glucose log, and apply those to CGM. So in order to do that, we kind of broke it down into 4 basic steps. The first step, which is very apparent when you're looking at a glucose log, is not as apparent when you're looking at a CGM report. So this we kind of have to add more consciously into our process. And that step is just, are there enough data? Do you have enough glucose readings to really make management decisions? And so if a patient brings you in a glucose log and there's 2 blood sugars on it, it's really apparent. Like, you don't have to think about that. You realize immediately that there are no blood sugars, and so it's going to be hard to make management decisions. On the CGM report, they're going to give you a lot of summary metrics, and they can summarize a day and a half of data without you realizing it if you don't look at these things. So the first step is figuring out how many days of data and how active the CGM were. And so these are 2 ambulatory glucose profile reports from Dexcom Clarity and LibreView as examples. And you can see that they provide the date range, and you can customize that when you're generating your reports based on the last time you saw the patient, and then the percent time that the CGM was active. So we recommend at least about a week of data, 5 to 7 days of data, and at least 70% of time active. Otherwise, you just run the risk that you're making management decisions based on a single day, which may not represent the overall pattern of glycemia. Your next step is there a problem? So thinking about our normal process when we're looking at a glucose log, you're typically then looking to see, are there high blood sugars? Are there low blood sugars? Or are they meeting our target? And we're doing the same thing again here, but instead we're using our time spent in range with those recommendations. That's found at the top of both of these reports. Average glucose can also be very helpful and clue you in if there is hyperglycemia happening overnight, because you may have a high percentage of time within that goal range from 63 to 140. But if they're hanging out at 120 or 130 all night long, this average glucose is going to be higher, whereas really for pregnancy, our average glucose goal should be closer to that 100, 110, which we saw from the normative data. But that's your next step, is figuring out, are blood sugars too high? Are blood sugars too low? Or are they where we want them to be? Then the third step is trying to figure out where is the problem or when is the problem happening across the day. So again, kind of thinking back about how you would review a glucose log, you are looking at, are we having problems with fasting blood sugar, or are we having problems with blood sugars after breakfast, lunch, and dinner? And so that's really the same thing that you can do here. These graphs in the middle show glucose trajectory across the 24-hour period, and I'll show you in a little bit more detail how you can use some of these different lines. But basically, you're looking to see, are there problems with overnight control and preprandial glucose control, or are we mainly having issues with excursions after meals? Similarly, if there's lows, when are those happening? The one thing to point out on this LibreView AGP report is no matter what you customize on the CGMs, you can change the target range. This report itself is always going to be the standard 70 to 180. So these times in range on the LibreView report are not going to be your time in range for pregnancy. And this graph, your upper and lower limits are the 70 to 180 non-pregnant goals. So if you want to see the pregnancy targets that you have customized, you just have to use this snapshot report instead of the AGP report. But diving in a little bit more to these graphs, which sometimes I think can be intimidating. So when thinking about where is the problem or when is the problem happening, a few things to point out. So to orient you, your 50th percentile or your median, generally approximating an average is this bolded line in the middle. And this is the example from the Dexcom Clarity report. You then have your 75th percentile border, which is up at the top. And this is a great line to pay attention to because we want our time above range to be less than 25%. So anytime this line is going above our 140 upper target for pregnancy, that's your kind of signal that that is an area of hyperglycemia that needs to be addressed. Similarly, your 5th percentile line, if we want our time below range to be less than 4%, you're obviously going to pay close attention anytime this one is going below 65, and particularly if it's going very low, below 54 milligrams per deciliter. But essentially, you're looking through and seeing where am I in range, where am I above range, and where am I below range. And then the last step is fixing the problem. And so these are the same things that you would do in terms of diabetes management if someone was using a fingerstick log. So the first is always reviewing the data with the patient, asking for their input. With CGM, it's really helpful if patients can log their meals and log the timing of their insulin injections, but asking them how that's going. Are they having issues with false low readings overnight? And so you can really get a lot from a patient talking to them, and that does not go away with the use of CGM. Then the second key management principle is you have to address hypoglycemia first from a safety standpoint. If you have a glucose log and you're seeing values of 45 and 54 and really low values, I think inherently they are catching our attention maybe a little bit more than the CGM reports, but you have to kind of force yourself to look at that time below range, make sure it's not greater than 4%. And if it is, addressing hypoglycemia first, using your typical strategies for any diabetes management with hypoglycemia. And then finally, addressing hyperglycemia. We know that increases the risk for adverse perinatal outcomes. And so doing kind of the typical things, increasing insulin, adjusting diet and activity, or using other medications to try and minimize those high blood sugars. All right, so we will go through a quick example, and then I think I just have a few slides left, and we'll open it up for questions. So a very simple example, we've got a CGM report from a patient that you're seeing in the office. So what's your first step? figuring out, are there enough data? We see that we have 10 days of data if you do your math, February 12th to February 25th. The CGM was active 100% of the time. So we have plenty of data to make management decisions based on. Second is, what is the problem, or is there a problem? So again, we're looking at our time in range and mostly our average glucose. And so we can see our time in range is only 64%. This Dexcom Clarity AJP or AGP also gives you, you can cheat. It's got the goals there for you in case you forget. But our time in range is less than 70%. So that is a problem. Our time above range is greater than 25%, so we've got a hyperglycemia problem. Our time below range is meeting our goals, but this is still something to talk with the patient about if they're having 2% hypoglycemia, to make sure that the adjustments that you make don't worsen this hypoglycemia, but technically at meeting our goal. So now we know the problem is hyperglycemia, as evidenced by our high average blood sugar. So then the next step is going to be to use your graph to figure out where is the problem, or when over the course of the day is it happening. So we see our 75th percentile line that's peaking up above 140. So it looks like we have some postprandial hyperglycemia after likely breakfast, lunch, and dinner. And looking at the daily CGM reports may also be helpful. But we also, and it's hard to see on this graph, her fasting is greater than 95%. In Dexcom, you can generate one of the other reports. We'll give you the average blood sugar by hour. That's kind of where I confirmed that this was greater than 95. But the other way, again, our average blood sugar is higher than we would expect. So that is another something that we have to be a little bit more conscious about when looking at these CGM reports as they exist currently. And then last is how to fix the problem. So we've got hyperglycemia. So we may increase or start mealtime insulin. We may ask them to take their insulin a little bit earlier if it's just delayed absorption. We may review their diet, their physical activity level, and then for this elevated fasting and overnight blood sugar, increase or start basal insulin. And so some key takeaway points, CGM, I think is quite exciting, offering real-time detailed glucose data that just provides us so much more information beyond fingerstick or SMBG. We have strong evidence that supports CGM use in type 1 diabetes, but really the data for type 2 and GDM are still emerging, so more to come. We know that normal CGM patterns in pregnancy have, emphasized that you can achieve really high time spent in the target range with very little variability across the day and across pregnancy. And then hopefully I've convinced you that CGM reports can be, made somewhat simple and easy to interpret using some of the pearls you already know from blood glucose log measurement to incorporate it into your practice. So lots of things coming, which is really exciting. We've got many trials here in the US as well as across the world that are looking at, is CGM beneficial for patients with type 2 diabetes and GDM, particularly with regards to neonatal outcomes, and explain what CGM metrics should be used. Other things that we're going to have to ask is CGM cost effective for management of type 2 and gestational diabetes in pregnancy, as well as what metrics should we be using? What are our goals for this patient population? We then kind of taking CGM a step further, what are, some of the other ways we might be able to apply this cool technology. Newer studies are emerging, including the Imagine trial, which is getting started now, to see if CGM can actually be used to screen and diagnose GDM during early pregnancy. And then some studies coming out looking to see if CGM could be used postpartum after a pregnancy complicated by GDM to screen for persistent glucose intolerance after pregnancy. And then finally, if CGM is beneficial, we have to make sure we can equitably implement CGM in pregnancy. I will put in a small plug for a new registry study that's for type 1 diabetes in pregnancy. This is a study that any of your patients can participate in, so feel free to share this with them. I can share these slides, but essentially this is a study that's just collecting information on patients with type 1 diabetes who use a CGM to figure out, are they using a pump? Are they using a hybrid closed loop? What strategies are they using to treat their type 1 diabetes in pregnancy? So we're enrolling across the US, and feel free to share this with any of your patients. And that's all I have. So I'm happy to open it up to questions, and look forward to hearing from you guys.
Dr. Battarbee, thank you so much. That was amazing. Well, no one has raised their hand yet. I don't know if my question is appropriate for you or not, but it seems like for 10-year-olds or 12-year-olds with type 1 diabetes, having a closed loop pump, synced to their continuous glucose monitoring has to like revolutionize childhood diabetes. Do you have a comment?
I'm not the expert in pediatric diabetes, but yes, agree completely. And I think there are more and more hybrid closed loop algorithms and pumps coming out that also make it more user friendly. There is a pump out there called the iLet pump, which doesn't require users to be able to calculate carbohydrates, and really requires very minimal interaction with the pump. And so particularly good for that population, or even anyone who, number one, doesn't want to spend all day trying to control their diabetes, or maybe doesn't have a lot of health literacy. So that pump right now is not great for pregnancy because you really can't customize it at all, but it is really great for other populations. So yes, and I think we're going to find, whether we like it or not, that CGM is going to really take over diabetes management. I think finger sticks are for kind of routine monitoring are going to fade away, but offer some really cool, exciting things for future of care.
I see that Dr. Patrick has her hand up.
Thank you, and good morning again, and thank you so much for this talk. I think this is a very exciting area, and I appreciate all the work that you're doing. I have, I guess, sort of a practical question. We, in our MFM division, are starting to use more CGM and GDM and type 2 diabetes. A lot of that is very patient driven, like I said, including myself. And what I'm discovering is that, unlike our type 1s who came to us usually very CGM savvy, having been using it for years, there's, you have to kind of figure out the mechanics of the CGM. I personally knocked off more than one accidentally, I think as a placement. The whole issue with the arm compression at night causing hypoglycemia alerts is very common. And I'm wondering if you could point us to like a good resource, I guess, for, CGM for dummies. Because it's hard to have time to go through all of those, caveats with people in the office.
Yeah, that's a great question. There's another talk that I give, which is more logistic, nuts and bolts based. And I think the first piece that I would say is it's great to get your whole office involved in figuring out, who's going to help with the prior authorization, who's going to help with the downloading of the data, who's going to help with some of those troubleshooting, because some of those steps are very straightforward, and you learn them once, and it's very easy to do, that anyone in your office can do, so that it's not all put on you or the patient. The second thing that I'll say, there is a great resource out of out of Colorado called Panther Diabetes, Panther. I can drop the link in the chat before we end, but if you Google Panther Diabetes, they have incredible resources for both CGM and for insulin pumps, information about the devices, information about how to read the reports, as well as troubleshooting for, what are 5 strategies when the CGM keeps falling off. Using, some skin tack adhesive on the skin before putting on the device, using extra over patches, a number of different things that you can do, and then troubleshooting. What do I do if I've got a skin irritation from the CGM? And they've got all sorts of strategies. Spray some Flonase on before you apply the CGM, put on a Tegaderm on the skin, and then insert the CGM essentially through the Tegaderm. So the Panther Diabetes is a great resource for some of those troubleshooting. And then finally, I would actually say, utilize your local reps, utilize the websites. They have great informational videos, and many of these companies are, excited to get more pregnant patients using CGM, and so can be very helpful in troubleshooting and providing education as well. So, yeah.
Dr. Rosen?
Hey, Dr. Battarbee, thanks so much for giving this talk, and really needed. We should stay on top of these changes as they occur rather than just follow what others are doing. I'm not sure if I heard this from you during the talk. You may have said it, I may have missed it, but has this technology improved compliance of patients, specifically in pregnancy, with glucose monitoring?
That is a great question. There is very limited data out there on that. We have a small retrospective study that we're working on getting published right now that does show improved compliance in terms of having glucose data at the time, but people kind of skip that step and jump straight to glycemic control and neonatal outcomes in some of the studies. So there isn't a lot, but I think it exists, and I think there is improved compliance, but we're working on a second, like a retrospective cohort study that hopefully will get published here soon.
Yeah, I think it's an important question, and we all have our really recidivist patients or recalcitrant patients who will make up their finger sticks, which is hard to do if you're using a CGM. I'm seeing currently 20 or 30 diabetics, either type 1, type 2, or gestational, and managing them remotely, one of our practices, largely commercially insured. And maybe I see half of finger sticks from some of our patients. So
Yeah.
It doesn't matter what the population is. Like, you have incomplete information. I think that would be helpful. This is the one question I really wanted to ask you, and I didn't see this, and I was doing internet searches while you were talking. Was the role, like the role for AI in the management of diabetes? It seems like the perfect modality to make this easier, reduce healthcare resources. Doesn't seem like there's anybody doing it yet, although there's a bunch of papers like, oh, we should investigate. Have you guys started on that in your research, or have any of the companies that are working, like any of the glucose monitoring companies working on this?
I know at a few meetings that I've been to, there have been in the non-pregnant space some AI algorithms that have been developed to try and help supplement the CGM reports of, we suggest potentially trying this or doing that. I don't know of a lot that's going on in pregnancy, but it's coming shortly. I'm sure there are people out there working on it. We're not working on it right now. I think one of the things that we will need for AI to help us is consistent logging of meals and consistent logging of insulin doses, because it's really hard for anyone, a human or an AI algorithm, to make sense of what needs to be done if they don't have the flip side of, you've got the glucose data, but what is happening on the other end? So did they take their basal insulin, or did they forget Are they taking their mealtime insulin actually after they eat? And so some of those things, I think, for an AI system to really work, we're going to need a little bit more input into the system, I think, from patients on a daily basis. But I agree completely. It is coming, and I think would be really helpful, especially, if you're, if you're a patient that's getting, care in the rural US, and maybe you're, following with just a PCP, or someone who's not as well versed in diabetes, to have that assistance. And then I think the other point that I'll make, going back to your comment about like adherence, I think that I think the reasons why CGM may be beneficial in different populations may be different, right? Like, does a patient with GDM really need to know their blood sugar every 1 to 5 minutes? Probably not. The same as a patient with type 1 diabetes, like they're going to have more significant changes in blood sugars and may need that, may need more data. I think, it also may overcome some social determinants and just provide data that otherwise doesn't exist. So I'm very curious, as we get more and more data, to learn, why is CGM beneficial in certain populations? Because I think it's probably going to be good for everyone, but I think the reason why it's good may actually be different depending on who you are.
I just wanted last comment, and then I'll turn it back to Dr. Ebert and the group. And thank you again for just a lovely talk. And it was really fun to listen to you, and especially someone so expert in this. Like, if you think about like ways of eliminating or reducing healthcare disparities, technologies like CGM and perhaps AI are great. Like, combine that with telehealth, like you don't have to be anywhere near a physician in order to get best expert care from somebody at the University of Alabama or other centers where people are expert. Like this, what you're doing with this type of technology, if you put the whole package together that we have, the whole the whole armamentarium, like you can do a lot of good for people who normally don't have access to care in this space. So thank you again for your talk.
Yeah, agree completely.
All right. Well, Dr. Battarbee, thank you again for this amazing talk.
Yes, wonderful. Thank you guys for having me. Happy Friday. I hope everyone has a good day.
Thank you. Yes. So we'll end it here, and I hope everyone has a safe and successful day.